Okay, perfect. So we are on YouTube now. Great. Back to here. Excellent.
Awesome.
All right. So we'll just get people, give some people some time to join. Those of you that are joining, good to see you back here. Prism Eye Rounds. We're doing this every couple of weeks. Started off in the pandemic. We thought it'd be over by now, but we're not over yet. So tell us where you're calling in from. Luis from Honduras. How's it going in Honduras? The boys are back. Yes, the boys are back from Honduras. I don't know if any of you guys have been down there. Have you been down there, Jeff?
Nope, not since I was in college.
Oh yeah, okay. We won't ask you about those days.
I still remember them, so they had to be pretty good.
That's good. Well, that's a good sign, usually. So tell us though, I mean, just while we're getting on board, I mean, you mentioned it earlier, but as you probably know, we're all kind of wondering what's going to happen when you're going to find out who the president's going to be. Is it going to be Donald Trump or Joe Biden? Any news yet?
Hey, we can't jinx ourselves.
Well, you guys are what? You guys are in West Virginia, right?
Yes, one of the reddest states in the whole country.
Oh, okay. So your state's you're the battleground. You guys are basically like locked in.
No, we're done.
You guys are done.
No question here.
We got Garth Wilbanks from Maine. Maine's kind of in the middle, right?
Maine went to Biden. Maine is blue.
Yeah, Maine doesn't have a lot of seats though, I guess. So it's kind of one of those like little. It's such a unique system. I mean, we're so in Canada. It's like popular vote, man.
How strange. I overheard someone trying to explain the popular vote the other day, and it was really funny to me. They're like, "What's popular vote?"
Well, yeah, technically Canada's not. I mean, Canada's a little. I mean, we still have a party system, so you have to have enough seats for your party to form a government. So that's
similar where I'm from too. I think it's a decent system because then you get sort of representation even if you're a smaller group. You have seats, whereas here it's kind of all or nothing. In the US, I don't know.
Well, we certainly are waiting, man. It's going to be.
I promised these guys a break from politics. You ruined it, Ike.
That's right. Sorry, guys. Yeah, I know. Well, I'll tell you what. Before we get started, I was up prepared, man. We had like snacks and we had food and drinks and we were like watching. I'm not sure why I did that. I mean, I was up till 2 a.m. and fell asleep on the couch. It's not like it's a Super Bowl or anything where you're going to get a victor after this, right?
They're talking about doing recounts and not having a result.
Yeah. So we need the winner needs 270.
Yeah.
So that's where we're at this hour, at the top of the hour.
Yeah. So Biden's 17 away. That's kind of close.
Didn't this happen last time?
I know. We got
deja vu all over again.
We got Muhammad from Ireland. So we got Ireland and Honduras, two folks that have piped in here, and of course many others as well. I think we will get started. So thank you all for joining us. I know that at different times for different parts of you around the world, and it's great to see people here. I see a lot of familiar faces that have joined us, and I know some will continue to join us, and I see people on YouTube as well. So hi everybody on YouTube. I know that's been an easy place to log in. Very excited to do our first topic more on the strabismus side of things, which is something that I'm usually used to creating, not actually addressing. So it's good to be able to hear the latest and the greatest and the challenges that exist in this place. Very happy to have my colleagues here, both from relatively far away from West Virginia that Matt will introduce, and of course Andy Budning, who I've counted on as a colleague. We work together at the same institution at the University of Toronto and Trillium Health Partners, and he's certainly been a huge asset for us in managing strap, both adult and pediatric, which is really great. I often joke around. I say Andy does a strap surgery, faster than many of us do phaco. He's very efficient and very good, and actually has great outcomes. And so he's not only doing great work, but he's also very efficient. I'm going to get Matthew maybe to introduce everybody here today, and then we'll get into our program. And of course, as usual, love to hear Q&A and chat and questions. So use the chat line, use the Q&A line. Matthew and I will follow that. and looking forward to a great webinar, great rounds. So over to you, Matthew, who's been
Thanks,
organizing these.
I've done a bad job of following the YouTube chat in the past, so I have it up this time. All right, let me get my screen shared over here. Okay. It always seems to default to the wrong screen, so let me switch these around. There we go. Can you see that? Let's go to the beginning. Okay. All right, so our topic today is double trouble. So we've got some talks from Ryan McGuire, who is one of my buddies who got me into ophthalmology. So, you know, I owe a lot to him. And, you know, I know he's a really smart guy. So I said, hey, come on in and chat to us about something I know very little about. We cause a lot of strabismus and glaucoma, but, you know, let's hear about how they fix it on the other end. And then very grateful to Dr. Bradford, one of Ryan's colleagues, for joining as well as a panelist. So thanks again, guys, for being here. Dr. McGuire did his fellowship at CHOP in Philadelphia. That's where we, you know, cross paths in Philly. Residency at Drexel University College of Medicine, also where I went to medical school. And then he did his MD in Ohio, Northeastern Ohio University College of Medicine. Our guest panelist, Dr. Bradford, Peds Ophthalmology Fellowship in Atlanta, and then residency in Akron, internship and special training. I didn't know what that was, but I started off your website. And then also got his MD from Penn State University. Thanks for joining us, Dr. Bradford. And then we have a Toronto local, Dr. Bunning, working at Trillium Health Partners, also at Hospital for Sick Children, and University of Toronto as associate professor, interest in strabismus, amblyopia, and retinoblastoma. So this should be an interesting one, guys. I'm going to hand this over to Dr. McGuire.
All right, let's see if this works. All right, do you guys see just the presenter view or the? We
do, we see it.
The presenter view or the actual just presentation?
The actual presentation, yeah.
Perfect, perfect. My original thought was, let's go and try and come up with some surgical management of diplopia and cranial nerve palsies. But, you know, strabismus, as much as it is a science, there's definitely an art to it. And depending on the situation, depending on the patient, and depending on what their goals of vision are, there's a lot of different ways that you can manage even a single, you know, type of cranial nerve palsy. So my goal was to just come up with a couple of quick, very dirty cases of cranial nerve 6 palsies to kind of promote some discussion and think of different strategies to treat and assess and hopefully make these people happy. I know personally, you know, being in peds and in adults that, you know, you might just be kind of, I have no financial interests or to disclose, and here we go, never mind. Here's a couple of cases of diplopia. I kind of breezed through that already, and so in me, it's like, here's me, you know, just kind of in the eye lane, everything's going great, and all of a sudden your tech comes and tells you you got an adult with double vision, and I just know that it just kind of stops you in your tracks, and that it really can put a hamper on your clinic flow and your clinic schedule. So it's nice to come in with a good plan, because you're trying to go and take these people who are seeing pretty much some very, very difficult visual circumstances. At least where we are in West Virginia, most, if not all of our patients are relying on driving, and double vision is an extreme barrier to them getting access to healthcare, access to their work, and it's an extreme quality of life problem. And fortunately, we have a lot of good solutions, and I hope that by the end of this talk, you'll have a better understanding of some of the different ways that myself, Jeffrey, and Andrew go and manage these. So let's start off with something simple. First case, 62-year-old male, type 2 diabetes, hyperlipidemia, coronary artery disease, hypothyroidism. Could be in any clinic in the world really. He has apparently been wearing an eye patch since March of 19. So he has been walking around for over a year by the time he comes to see me. He was originally seen in our ED, diagnosed with a cranial nerve 6 on the left. Workup was negative, sent home, told to come back. Comes back a year later saying that, you know what? I think now's the time that I want to go and have my double vision improved. And I was like, man, I always thought to myself, I wonder what the holdup was. But he said that the patching was doing great, but now the patching is starting to get a little bit annoying. So right now he's tried patching, and then he went to our resident clinic and was given some Fresnel Prism. Problem is that the guy had really excellent cataract surgery in the past, and he doesn't really need glasses. So he's 20/20, and I think that's what really bothers him the most, is that he otherwise sees really, really great, and wearing Prism and the chromatic distortion from the Fresnel Prism really is a pain for him. To just kind of break it down, this is kind of what he has. This is his strabismus exam on alternate cover without correction because he has no glasses. Basically, he's got a left ET, relatively small amount, but it's constant, and it definitely gets worse when he is looking into left gaze, and he has a little bit of restriction, but he can move it almost all the way out. So this is a guy who has almost full motility, but still was given a lot of discomfort. And there's really no place, no matter where he's looking, that gives him a good resolution of his symptoms. I did do Maddox rod testing. I'm a big fan of dissociating to see if there's like a latent component to their manifest strabismus, because it gives me a better idea of how to aim. I tend to aim high on these types of cases, and also considering, talking and discussing about adjustable sutures for this, because I think it really has a place for patients like this who have essentially partially resolved cranial nerve palsies or cranial nerve pareses. And I was wondering if for Jeffrey or for Andrew, like, how would you approach this patient, as a strabismus surgeon primarily? What are your thoughts initially?
Initially, it's an interesting case. As you said, it unfortunately took almost a year for him to come in and see you. Sometimes if you can get these patients in earlier, you can hit them with a little bit of Botox to decrease the amount of restriction that they end up with. But nevertheless, I think you're right. Many of them do show up at this point, and there is a bit of incompetence there. But really, I think it's really important, as you said, it can really impact on their life to really go through their history and find out what is their biggest problem, what bugs them the most, and then discuss with them that you can't make it perfect, that there is a bit of a nerve palsy, and get their expectations in line with what's possible. In a case like this, because it's mostly the left eye, as you said, and you can see on left gaze you have an increase in the LET. You certainly can recess the left medial a fair bit to allow the eye to turn out better and improve your position straight ahead. Sometimes when you do that, you do end up with them being bothered with still some residual diplopia on left gaze. And then you have other little bit more complex possibilities if you really need to, if they're really stuck, such as using a posterior fixation suture on the right eye to limit how far that can look over and improve that a little bit as well. But really, you want to start as simple as you can and make sure that their expectations are as good or in line with what's possible, because you can't make it perfect, and they need to understand that. And then see, as you said, adjustable sutures, I guess we can talk about maybe after Jeffrey talks a bit, but I'm certainly as well a big advocate of adjustable sutures. I'll let Jeff chime in.
Well, I can't disagree with anything, Andrew. I would manage this patient surgically in probably the exact same way. Since I don't know this patient personally, I think I would ask him how opposed he is to having a pair of glasses. He certainly has the independence after his cataract surgery of not being dependent on glasses for his distance work, but he still has to wear a bifocal. And ET of 12 in primary gaze is something that could be corrected with a prism prescription, not a Fresnel prescription, but a ground-in prism prescription. I'd probably split it in half, 6 on each side rather than 12 on the left side. Depending on how bothered he is by his diplopia, maybe there's times during the day where the diplopia doesn't really bother him. Other times there are. Having a pair of prism glasses might be a way to give him an opportunity to see what non-surgical treatment is and how much benefit non-surgical treatment might offer him. So I wouldn't be opposed to, especially if he has significant comorbidities. He's the kind of person that I may, if it seems prudent, talk into trying a pair of ground-in prism glasses before going to surgery.
Just to kind of move on a little bit. So basically, you know, he could continue patching. These are some of the discussions that I'd had with him. Increasing prism to improve symptom-free periods and strabismus surgery. After kind of mentioning all, you know, pretty much all the topics that you guys had already pointed out, I think he was more trying to remain glasses free, went more with the strabismus surgery. And we ended up doing a surgical plan was a left medial rectus recession versus resection. I tend to lean towards the left medial rectus recession because I had a pretty good suspicion that he would be positive on forced ductions, especially considering he still had some residual even in right gaze. And, you know, I always kind of plan just in case I end up needing to use the, you know, do a lateral rectus resection. But what I ended up doing for him was I did a left medial rectus recession, adjustable, and I usually plan for the one muscle surgery because it was there was some positive forced ductions under anesthesia. You know, this is kind of I tend to use the Ken Wright surgical dose table. I know everyone kind of uses their own, but essentially I was aiming for a target for a little under 20. And then I set it for about, you know, between a 20 and a 15. You know, you double it because it is just one muscle. So I believe I put him for the esotropy. I believe I put in for like somewhere about a 5 and a 4.5 to then kind of augment at a later date. And when I mean a later date, typically in our hospital, we do the surgeries in the morning, let them recover in the recovery area for like 2 or 3 hours. And then we do the adjustments that day, same day as the original surgery in the recovery area. Now, in my fellowship, we used to go and do these the next day in the office. It's just unfortunate that my OR day is on Friday. So office time on Saturday is not something I'm super excited about. So that's how I had it set up. You know, do you, Andrew, do you typically do any of your adjustables in the like in the recovery area? Or do you wait till the next day?
No, I'd say actually 2 things. As far as the amount to do, because the lateral is weak, I find over time, these patients 2-3 years later come back with an ET. If you do sort of, you know, a medial of 4 gives you about 12. It's about a 3-to-1 ratio. So they tend to drift in. So you could even push it to a 5 or a little more with an adjustable and see where they are after. I tend to do a slip knot like David Hunter. We've actually done a fair bit of stuff together, but that allows you to only adjust if you have to adjust, which is nice, so you can leave it. And I typically will adjust about 2 days after. You could actually push it to 3. I did a study of a few hundred patients. And if you go out past 4 or 5 days, then it gets sticky. But I'll bet you with where you are, if you did have to leave some, or you started to leave some for your operating Friday, you could probably do them Monday morning if you felt it's better. But one study that I really want to do, I'm partially through, but is to see what's the change in the angle between the afternoon, if you did an adjustment that day, versus 2 or 3 days later. And I haven't found anyone who's really looked at that, but I think the eyes always do come out a bit, so that would be really interesting to look at. But I think it's nicer to do it a few days later. The eye is calm, and you can really see where the eye is settled to, so you can decide if you want to adjust or not.
It'll be a study titled "Saving Ryan's Weekend."
That's pretty much what it would be. You know, this is kind of in the case, you know, the idea of doing adjustables versus the conventional group. Basically, out of 4,357 horizontal surgeries, about, you know, and this was not for cranial nerve palsies, but, you know, the number of patients that needed an adjustable or a reoperation in the adjustable group was significantly lower than those in the conventional group. So for patients that have a lot of concerns for diplopia with these smaller angles, and you're really trying to, you know, because they're very intolerant of prism for whatever reason, this is the ideal case that I like to use adjustables for, because your margin for error is the smallest, at least in the short-term group. And this was study followed them for at least 12 months. It was definitely more for a horizontal. They also looked at verticals, but I won't go too much into that today.
Sorry about the rookie question, but so you're doing these under general, and
so
because I assume
you're tying the slip knot under general anesthesia, but
because
the adjustments are done while the patient is awake and alert, so that you can fine tune any of their symptoms. So
and
ideally,
that,
if they're having
it has
still
to be that
some,
way, right?
Yeah.
But now, what about? Do you have to sort of gauge these patients and their ability to tolerate adjustment while awake? Do you ever find yourself in a scenario where, okay, you have to put these in under general, otherwise they're not going to be accurate, and then you have to adjust them while they're awake, but then they won't let you do it? Do you ever get stuck in that scenario?
We run into that quite frequently when you're doing adjustable sutures in children, because not oftentimes they're not feeling great, and there's no way that you'd be able to get the adjustment done in the chair in the office, which is why I want to say I typically do almost all of my adjustables on adults. But there are a significant number of strabismus surgeons who do them on every strabismus case, and they will do them under general anesthesia. They'll see them in the recovery, see how they're doing, and if they need to make an adjustment, they'll have them go back. Otherwise, they can tie them off.
I see.
Sometimes they just need something like light sedation, which can be done, you know, without re-intubating the patient. So that
you'd have an idea how much to adjust, you know, then you can take them back and then adjust, and then, or is that
I've never had to readjust more than twice. You're just, you know, we're really working with just a small amount. I tend to make it so that it's, you know, if anything, I'm going to be loosening it as opposed to tightening the suture. So I tend to over estimate, and then if anything, you're loosening it a tiny bit. I find that's been a little bit easier for me personally when doing the adjustable sutures.
Gotcha. Cool. Thanks.
Yeah, I can reiterate that. I think it's a lot easier to recess an extra millimeter or more than what you think you might need, and have the ability to pull the muscle forward with your slip knot. It's harder to push the muscle back. So if you haven't done enough surgery, you can still get it back there. You can nudge it back with like a small Stevens hook or something, but it is a lot easier to pull it forward a millimeter or two than to try and get it further back.
Yeah, absolutely. Sort of unlike your little picture there with the short tag noose or the short adjustable, you tie off those long threads so it's buried underneath. And the kids or adults, because I do it on a number of kids, and we'll just have a peek at them when they're waking up, but also even just while they're asleep, if you're trying to do whatever by medials of 5 millimeter recessions, just to make sure that your muscles are exactly where you want. Because I hang everything back, I find I feel better and the safety is greater. The last thing you want is an infection. Going through the insertion is pretty much the thickest part of the eye. So it allows a little bit more safety, and then you can be pretty certain that you're exactly where you want to be. So that's another advantage of an adjustable. And having that suture, I'd say 1 in 1,000 creates an issue. It's very rare for the suture in to do anything. They just absorb over time. It's just a bical suture.
And then it's really important to have some preoperative communication with your anesthesia team, because unless your center has extra OR time, which very few centers do, you'll find that you get to the patient to the recovery room and say it's a patient, an adult who just can't be adjusted, they can't tolerate, they're squinting too hard even with a lid speculum in, or if it's a younger child and you need to take them back for some sedation in the OR room, unless you've communicated with the anesthesia team ahead of time, you may find that they don't have any room for you to put the patient back in the OR. So it takes some coordination at the front end so that you have the opportunity to take the patient back if need be for some resedation in the OR room. Just good comprehensive pre-op planning.
Yeah, and typically, just so you're aware, when I do it a couple days later, usually we'll use certainly topical, but I'll also inject a little bit of 1 or 2% lidocaine with that epi underneath the conj. Really numb it down, use a Q-tip, hold it for a while. And I'm kind of lucky, I have a little operating microscope in one of our small rooms, so I can lean them back under that, and the patients are usually pretty good. If not, you sort of give them a little nudge on the side of the head and say, stay still. But 90% are good, and as you said, certain patients have a harder time. So once you get good at it, you can fly through it, but it's not something that's comfortable for the surgeon or the patient sometimes.
Yeah, we've got a small minor room in our office. We just have to fight our oculoplastic surgeons for time. They're usually doing tabs all day, every day. So that would be pretty cool to do. So case number 2. This one is a really tough case. It's a 15-year-old boy. He had a history of a low-grade glioblastoma on the left aspect of the pons, which preoperatively, he did not have any ocular misalignment, because oftentimes neurosurgery will have us come and take a look at some of these kids looking for papilledema. You kind of get them, and he actually really didn't have any real ocular involvement at the time. So what they did is they scheduled him for surgical resection, and post-operatively, he gets this large left esotropia and was a pretty diplopic to the point where he was throwing up afterwards, and they thought it was more than just what was normal for his neurosurgery. The main concern that I ran into when I was dealing with the oncologists and the neurosurgeons is I have this kid with a large left ET, and what do you do when you run into somebody with an acute palsy and they have, let's say, chemotherapy or radiation planned for the next couple of weeks or the next couple of months even for this kid, because I don't believe they got clear margins. So I know he was on chemotherapy from March to October. So that was a good 6 months.
Ryan, I don't know if you can hear me, but I think your screen is frozen.
Oh yeah, it's frozen. Can you hear me now?
Yep.
Oh, sorry about that. So my question to the group was mostly because, we run into these patients who have tumors quite often, particularly brainstem tumors, mostly and at least in my pediatric patients. When do you find is a good time to intervene surgically when they're getting active chemotherapy and radiation?
Well, fortunately, Andy, you may have more experience in this than I do, but it's fortunate to say that in my neck of the woods, this sort of patient doesn't come along very often. So, but I think for me, I would be more comfortable approaching this patient surgically when their cancer therapy is completed. I'm not sure that I would want to operate on them during their cancer therapy. Fortunately, he's 15 years old, so we don't have to worry about amblyopia, but in a younger child, there would definitely be amblyogenic potential with this strabismus, so there'd have to be some compliance on the family's part with consistent patching to either treat the amblyopia or prevent it while we're awaiting the hopefully the good outcome of the chemotherapy. Andy, I'd certainly defer to you if you have more experience with these types of brain tumor patients in your neck of the woods.
Well, you're certainly right. I mean, I have some experience. They're pretty tough, and one of the big problems, as you're alluding to, is with the chemo. You know, probably their white cells are knocked down, and they're at high risk for infection, and you got to be pretty careful with them. And they're also going through incredible family and personal struggles at this time. It's a pretty stressful time for the whole family. Certainly surgery would not be the first choice at that point, even if you knew that the damage was going to be permanent. Sometimes they, you know, if it's just a stretch on a nerve, it'll recover. But I suspect here it's a surgical complication. I think this might be an opportunity where you could hit the young gentleman with a bit of botulinum toxin. If he's up to it, which he probably is. They're usually pretty stoic, these kids. They've been through a lot, but if you can get the medial, you should be able to at least turn the eye out enough that you can lead to more single vision or put a Fresnel in. So at least he's not going to have that crazy double vision and the nausea and everything else associated with it. It may also help over time if there is going to be any recovery of the lateral. It might help with that, but most likely there isn't going to be that much more. So that's definitely a tough issue with that.
So that's pretty much exactly what I did. I did a Botox injection right into the, to the left medial rectus, and it really didn't do much of anything. I had to actually take him back to the OR for a multitude of reasons, but mostly because of patient cooperation. He'd been through a recent brain surgery. He was, although 15, not the greatest kiddo in the world to kind of examine in the chair due to a couple of other comorbidities that he had. And I typically injected about 5 units into the medial rectus, and since I was taking him to the OR, I actually just did a little bit of a direct visualization, small opening into the conjunctiva, injected directly into the muscle to kind of limit any potential for ptosis as a complication of the injection. We also do Botox, fairly regularly in the office in our minor procedure room. And I believe we were talking earlier about you using basically the EMG testing prior to. Can you just kind of describe that to the group so we get a better idea of like that sort of technique?
Yeah, sure. Actually, 2 things just before I do that. The first is I think you can go more than 5 units here, because the worst you can do is induce some ptosis, which is going to take away his double vision, and he's going to feel a whole lot better, and it's going to settle back down in the next 3 to 6, probably about 5 or 6 weeks. So you warn him ahead and say, hey, your eyelid may drop. There's 50-50 chance if you're putting in 8 or 9 units, but we really want to hit this muscle as much as we possibly can. And if it comes down, well, they're going to be used to it, and he's going to say, oh, hey, that's funny. He probably won't even be that bothered because the double vision is going to go away. And as you said, he's out of amblyogenic range. When you're using EMG with botulinum toxin, you have certainly for the medial rectus, you're going straight back in the orbit. The side of the eye is about 6 millimeters to the side of the center of the pupil. So you can go in almost near the carbuncle, and you're going back. Often you can go not that far posteriorly. You'd be surprised if the muscle isn't recessed already. Usually, sometimes 5 to 7 millimeters, even though the muscle belly is farther back. But I believe it was some of the guys in Mexico found that you can inject pretty anteriorly, and the Botox tends to track along the muscle and is pretty effective. So I find with a lot of the medials that I do, you can inject as soon as you start to get a good signal. And usually, you're right, usually for other cases, we'll do about 4 units on average, between 3 and 6, but often around 4. For the lateral rectus, when you have to do it, it's a little more complicated in that if you go straight back there, you hit the bone for the lateral orbital bone. So you have to go back probably past the equator area of the eye, and then you rotate the needle posteriorly, and then you get towards the muscle. The inferior rectus, you go through the lid the same as you would for a retrobulbar, except you go more centrally, and you get it. The superior, you don't tend to do Botox. It's just not in a good spot for it. So you certainly can get most of the muscles, and it does definitely help. And you can use it for many things. You can also go posterior orbit if you have a really bad nystagmus. Often it's an ICU patient where they've got a syndrome associated with that, and that'll also settle down the eye. So that's not a common thing that we do. The most of the needles are about 27 millimeters in length, so you can go back pretty far if you have to, but you really don't want to, and you have to be careful with bleeding. It's rare, but with any injection you can get bleeding, and you have to be ready that if you did have, especially laterally, you may have to do a small lateral orbitotomy. I think I've come across that once, but it is possible, and you have to be ready for it.
Ricky
Andy, I have a general question. I don't know the answer to this myself, but I understand on our specialty listserv that there is a new botulinum-like product that's come onto the market that I suspect is less expensive than Botox, because I understand hospitals are purchasing it and perhaps not always telling the pediatric ophthalmologist that they're not carrying Botox anymore. I gather that the dosage is about twice what we would use for Botox. Are you familiar with this new product?
I don't know that product, but there is another one. I'm just trying to think of the name that doesn't need refrigeration. And the other thing with Botox is they do have 50 unit vials. The thing is, we're using 4 to 6 units out of a 100 unit vial, and then you're throwing away the rest of it. The 50 unit vials are half the price. But yeah, I wouldn't be surprised. I'm just trying to, probably the name will come to me in the next bit.
Yeah,
but it's been,
I'll continue to think of it.
Yeah, but it doesn't need refrigeration, which is a good thing with it. The other thing too that is interesting with the Botox is when you mix it up, usually I do that myself, you have to add the saline very slowly, because you can denature the protein if you put it in too fast. So you have to be very gentle with the stuff as you're reconstituting it.
Ricky Enzo had a couple of questions. Oh, go ahead.
Oh, I have nothing productive to say other than we never throw out our unused Botox. There's lots of middle-aged ladies in our clinic that are welcome to line up, and our oculoplastics person is very popular after we do Botox for strabismus.
Right.
Ricky Enzo, one of our budding glaucoma enthusiasts, is asking, if you decide to do surgery after injecting Botox into a muscle, how long do you have to wait to get good measurements?
Typically, I don't plan surgery soon after, unless it's something like a third nerve palsy and I'm doing a transposition, or in a, and you really want to weaken the medial rectus, a lateral, as this one, and you really want to weaken the medial rectus so you can transpose the superior and inferior and hit the medial with Botox, because you can't do more than 2. So with a 6 nerve palsy, not 3. Usually I won't do anything for at least 6 months if I can avoid it, because you just don't know where the eye is going to end up. Sometimes it'll last longer. It'll last 8, 9, 10 months. So really, if you're planning surgery, you need to warn them we're not going to be doing anything for a while. But if it is a new 6 nerve palsy that you're just trying to prevent restriction or the muscle tightening up, then you tell them I wouldn't be operating on you for a minimum of usually a year to let this thing heal the best it can, and this is going to help it to heal.
Thanks. There was another question of how long would you wait before treating a misalignment in say, a 15-year-old? And then what is the age threshold for using a patch if they're bothered in the short term, I guess worrying about amblyopia?
Well, I would say that if you have a very young patient and they're patching, it's probably prudent to have the patient come back regularly so that you can monitor their amblyopia as well as monitoring their palsy. So if they're actively patching, I'd probably want to see the child, depending on their age, rather frequently, and not just say to a young child, start patching and come back in 4 to 6 months and we'll look at your strabismus then. I'd want to be careful about not inducing amblyopia on the side that's patching. If it's not a complete palsy and there is some movement to the eye, it wouldn't be too problematic to have the patient patch one eye at one point in the week or during some activities, and maybe even patch the other eye for other activities or other times during the week. They could alternate the patching. The patch for this 15-year-old would be certainly to avoid diplopia, not treat amblyopia. And if their paretic eye was at least somewhat functional, you could be patching the good eye or the bad eye. It wouldn't really matter. It's just that the patch would help with the diplopia.
Thanks.
I'm not sure if I answered the whole question.
No, yeah, thank you.
Now, this is just funny because I just wanted to include this talk because if you actually look up botulism toxin for the treatment of strabismus, they actually say that there's no benefit for these acute cranial nerve 6 palsies, which I always thought was silly because I use them all the time with pretty good results. But if you actually go and dig deeper into some of these more critical papers, they're limited studies with low power, so it's really hard because I don't, and remember the Cochrane database that only looks at randomized controlled studies. So as opposed
do they
to
give
some
that
of the
a
other
rating
ones,
of not enough evidence on that Cochrane review, or do they recommend against?
They didn't have a recommendation.
Okay.
They just said that it didn't have strong evidence for, so they did not, but they did not recommend against. It was just, I think if you actually looked at the paper that came out in, this is the one from 2012, they only had 4 studies included in it. And I thought that was a little bit, it was limited, especially considering, I find there's a lot of utility for Botox in a lot of these cases. Unfortunately for this kid, it really didn't work all that well. So the next thought is, transposition surgeries. There's a lot of different types of transposition surgeries. There's the Hummelsheim, the Jensen, the modified Hummelsheim. But the one that I wanted to talk about would be the superior rectus to the lateral rectus. To just see if I could get a little bit in that. I'm a little bit worried. A lot of times I maybe in my own mind, I was worried about overcorrecting this young boy because, I just started, I did the case in October, after he'd finished with his chemo, after he'd finished with his radiation, and I didn't want to overcorrect him. So I decided to go and just do the one, and I could always make it, do the inferior rectus if I needed to get that later. Having done his Botox injection and knowing how well he reacted with trying to do adjustments, I went more for a conventional approach. So I actually didn't do any of the adjustable sutures immediately. He was very, very strong forced positive, and I pretty much did like a 7mm recession there just to loosen it up a little bit more. But what are your thoughts? Would you do in terms of a transposition for this case? Now, like I said, he was about a 60 of a left esotropia.
I would definitely do a transposition. I'd also, you'd already done Botox to the medial rectus, so that's been done. But I agree with the Foster modification with the augmentation to that. Probably with a -6, I would do both the inferior and superior. I don't think you'd get enough with just the superior because it's a big turn that he's got there. But just checking with neurosurge first and make sure that, as I'm sure you did, that there's very little chance that any recovery will occur. But you really need to pull that eye over a fair bit. I think you're going to end up still needing to recess the medial in time a fair bit with that.
Someone was curious what happens to the stump of these recessed muscles 3 months after surgery. Does it get attached to the sclera? I guess, that can be relevant for us, if we have a patient who's previously had muscle surgery and we go in and we're going to do a tube on them or glaucoma surgery or something. I mean, we've had that, things might look quite different.
Yeah, you'll often find that the stump of the original stump insertion has some fibrotic bands to the overlying tenons. It's usually limited to the area of the stump. It can be rather thick to dissect through, but just having good hemostasis, having a good view with your Westcott scissors, doing as much blunt dissection as you do sharp dissection, you can usually get through that pretty well. Usually with careful surgery at the outset, you're not going to have a lot of scarring posterior to the stump. So I think it's prudent to expect it, but it's not that hard to address it when you encounter it.
Thanks.
I think you could also at times, if you need to separate a little bit, or if you feel you're going to scar up, you can put a little viscoelastic underneath, just separating it. And by the time it separates, if you've done exactly as Jeffrey said, good hemostasis and keep it really clean, that'll keep it separated as well for that day or two while things are scarring down and healing and minimize the inflammation.
All right. Now, this last case is one of those ones which there's a 49-year-old patient. She had a partial hemispherectomy for seizure control, had a temporal lobectomy down somewhere in North Carolina. And right afterwards, she had a, right cranial nerve 6 palsy. She underwent, right medial rectus resection of about 5, a right lateral rectus resection of about an 8 at the time, which was done, like I said, in November of 2008. And she was good for almost, a decade and change. A young lady, but she doesn't drive because of her, she still has a seizure history. And it's not all the time. It's mostly in the AM and the PM, mostly when she's tired. She came to me essentially thinking that she needed an extra little bit of surgery. And I mean, she really was, fairly primary in certain gazes. She did have a little bit of an esotropia when you really broke her down, but it was quite a small angle. And after kind of talking with her, I actually decided that, maybe she just wanted a pair of prism glasses. So I basically fitted her for prism. And I just kind of wanted to include this, is that as complicated as this girl was, kind of after talking with her and getting what is it she really wanted. And really what she wanted was to read without double vision in the afternoon, because she would come home, she would go and she'd read her books as she was getting ready for bed, and she would get double vision. So really, I basically gave her a pair of reading glasses with some prism, resolved her symptoms without really having to do anything. And she was, extremely happy with me afterwards. So the nice thing is that it's, when push comes to shove, when your surgeries aren't perfect, it's really nice knowing that you can actually rely on, patient questionnaires. You can rely on patient symptoms to focus in on their main complaints, give them something like either a Fresnel prism or actually ground in or, prism in their glasses, and really kind of help make their quality of life a lot better. And almost always when I'm dealing a lot with these palsies, I'll tell them that I get fairly close, or we'll get a good amount of usable vision without prism. But, I always like to let them know that prism may be an option even with a really good successful surgery. And, basically, if you look at it, and if you look at, successful treatment of diplopia with prism, it definitely improves the health-related quality of life. And I included this, this kind of diplopia questionnaire that I have used for some of my more adult patients who I am not 100% sure I want to go and do strabismus surgery on, to see if there's any way I can kind of, get them, get them improving, and also to measure if what I give them is actually making it better. Because oftentimes I will see somebody, especially if it's like in the acute phase after cranial nerve palsy, where I give them a Fresnel waiting for them to get some recovery. I like to know that things are getting better versus things are getting worse. So I find that personally, I do use questionnaires on occasion in my adult patients, not so much in my pediatric patients, but at least in my teenagers, older children, and adults, to try and gauge how I approach their cases and what I can do to make their lives better.
One kind of neat thing that you can throw in there, if you go back, I don't know if you can go back to your last slide, is to always remember the slab off prisms, because they can be really helpful, particularly in vertical. Actually, one back just showing your angles, where you're sort of 3 to 9 in your angle with increased ET looking off to the right. If you use a slab off, you can actually increase the prism in that direction. On a horizontal, it's not such a big deal, but in the verticals, where let's say there's a limitation to depression, as they're looking down, that vertical increases more and more. So you can actually increase the power of your prism more and more by using the slab off. And they don't cost a whole lot more, but you can add an extra 5 to 10 prism of movement in that direction, and that really can make a huge difference for them when they're jumping into their reading position. So it's a good little thing, because prisms can be, as you pointed out, super useful and really improve their quality of life. And a slab off, which a lot of the optometrists don't even use, really can be a game changer, especially in the verticals, going into reading position from primary position.
Now, the case 2 was too much for prism, or someone was asking if it would have been suitable for that patient waiting for completion of the chemotherapy and in the meantime, etc.
Just trying to think if there's a
60 is a lot. I mean, you could add prisms together to get to 60, but it's pretty intolerable, and you'd get a lot of chromatic distortion if you were to try and use Fresnel prisms. So short term for him, I actually had him kind of alternate cover a little bit, but you'd be surprised. He was complaining of double vision, but his eye was so turned in towards the nose that actually a good chunk of his vision was kind of blocked by his nose. So I kind of feel like when I gave him the Botox and I got it a little bit better, he was actually a little bit more symptomatic, because I actually decreased it just enough so that he could really be bothered by it. And that's when I really decided that we had to do something else as soon as he finished up with his chemotherapy, because it just was giving him a lot of heartache.
So one thing maybe I'll throw in while I'm thinking about it in general, Ryan has presented some difficult cases here. So if we have a 6th nerve palsy patient whose etiology is tumor or traumatic brain injury, and we're having difficulty getting them to fuse in the office with a horizontal prism, and we don't really see much of a vertical misalignment, it still is prudent, I think, to pull out the double Maddox rod and consider the possibility that there's a multiple cranial nerve palsy and maybe a 4th nerve palsy hidden behind the 6th nerve palsy. So we always teach our residents that if the patient has some torsional diplopia, you're not really going to see that necessarily unless you specifically think of looking for it. And one way to really parse this out is to pull out the double Maddox rod and have the patient go through that testing and see how much, if any, torsion there is. And that might explain why they're not able to tolerate a prism. And we know that torsional diplopia cannot be treated with prism. And so they may be somebody that we decide on pursuing surgery sooner rather than later.
I think you've got a lot of glaucoma fans who've made a little paranoid here. Any thoughts on how to retrieve a lost muscle?
Well, it's a very steep learning curve. Once it happens to you, you'll never forget it. But honestly, if we settle down, the first thing to do when we lose a medial rectus muscle is maybe just set the instruments down on the Mayo stand and take a deep breath. And then think back to our orbital anatomy in our residency and medical school training, and appreciate that when we typically are doing strabismus surgery, we're looking at the muscle in direct opposition to the sclera, to the globe. But when you lose the medial rectus muscle, we have to remember that it is surrounded by a Tenon's capsule. Now we're dissecting part of that capsule away to expose the muscle for the strabismus surgery, but that Tenon's capsule that the muscle is in is like a long sleeve shirt. And so if we lose the muscle, it's going to be not against the globe, it's going to be up in the Tenons. And so you can stick the tip of your pinky in there and maybe you'll feel a little nubbin. That's one way to try and find it. Pulling out some instruments that we don't ordinarily use, like a malleable retractor or a Damare, to get some better visualization. That might help us. When we're looking for the muscle, we're going to have to remember that it's not going to be as pretty as we see it when it's attached to the globe. So it's going to be red. At the end of it's going to be hemorrhagic. There may still be some active bleeding from the anterior ciliary. And what we want to look for is that empty Tenon sleeve. So almost like a child pulling their arm up their long sleeve on a hoodie, we're going to try and find that empty opening to the sleeve and poke down through that with some toothed forceps and try and pull the muscle forward that way. We have to remember back to our residency days that the medial rectus muscle is the only muscle that has no other attachments to surrounding muscles. So the medial rectus is really the muscle that is most likely the one to be lost. If we happen to lose a lateral rectus muscle, it's less likely to go back to the orbital apex because it has attachments to the inferior oblique muscle. Similarly, the superior rectus has attachments to the eyelid retractors and the superior oblique tendon. So we're not as likely to lose a superior rectus muscle. But the medial rectus stands alone. And so I've lost two muscles, two medial recti. And the first one, I forgot to take a deep breath and set my instruments down and say, okay, let's just calm down, take a look here and be very thoughtful in just exploring the medial rectus area. And just remembering that we're not looking against the globe, we're actually looking into the Tenon's capsular area for that open sleeve. Those are my thoughts, but I have an N of 2 experience. Andy, I hope you don't have much experience either, but you might have some more thoughts on this.
I think you actually described it beautifully. A strange thing, but we gravitated for retinoblastoma when doing an enucleation to take the muscles off, and of course you remove the tumor, we'll call it, and then you go into the sleeves to find the muscles rather than putting any sutures through where you might risk damaging the globe while you're doing that. So your description of the sleeve was absolutely beautiful. I think you went through it perfectly. That's exactly, I think, the right or a great approach. So yeah, we certainly see that, and even the medial, as you said, gets caught up in that sleeve. And if you take your time and take a breath, very, very common to be able to find that. You don't want to wait too long, but take a couple minutes and then go after it and look for exactly the landmarks you were saying, a little bit of bloodiness, a little bit of stumpiness or swelling there. And you have an excellent chance of finding it. So it's not a time to panic. The other thing I was going to say is, if you are going somewhere that you may risk or you're worried about damaging the muscle, you can always throw a suture through it. Just grab a 6L Vicryl and just put it even around one side, just so that you have it tagged. There's times we're doing thyroids or other things, and you're just all over the place, or it's a re-op, and we don't know what's what. And just by putting a bunch of extra sutures in areas, if you're not sure it's something, throw in a suture. And if you cut it by accident, well, you've got your suture there, and you're going to find it very quickly. So make sure you know your landmarks. And if there's something you don't know, put a suture in it. It'll take you an extra 30 seconds, and then you're not going to get yourself into trouble. You're going to have it right there. Continue with your surgery, and then, oh my God, you did something. Well, you just pull your suture and you're back to where you were. So I think a really scary but important question to ask.
So I'm going to throw out some really quick scenarios that I think some of the cataract surgeons and refractive surgeons may want to know, and we get asked these questions as well, because we hate postoperative diplopia after doing a beautiful cataract or having LASIK done. These lead to certainly unhappy patients. So let's just start off with a patient who has a long-standing exotropia and has cataract now present in both eyes with reduction of vision. Is there anything that the clinician needs to think about or do? Specifically, again, assume they've had their workup and they've been seen as long-standing. They have no complaints of diplopia. Do we have to be worried about these patients, or we just go about do our routine refractive targeting and everything else? Any comments on that? I mean, these are quick ones. I don't want to belabor it. But just...
The real question is you have to think, is one eye amblyopic, and what is their dominant eye? So in West Virginia, I asked, a lot of our patients are hunters. So you say, what is your shooting eye, or what is your eye, your targeting eye? If you were in the military, you say, what is it that you used to use that? And they'll say, oh, my right eye was my shooting eye, or that, I am very right eye dominant. And if they have a really high amount of dominance and they have an exotropia, they may be suppressing, and they may have a suppression scotoma in that eye. When you go and you do surgery on the non-exotropic, or if you go and do surgery on the exotropic eye and you make it so that their vision is better in that eye, you can get some fixation switch diplopia in those cases, because the other eye doesn't have that suppression scotoma. So they are more likely to be symptomatic of diplopia, where prior to the surgery, when their non-dominant eye is basically drifted out, they're able to suppress that image. If you go and you make their non-dominant eye their better seeing eye, then you will run into a little bit more chances for postoperative diplopia. So I would always, that's why I always like to know.
The dominant eye is seeing well then?
So let's say their dominant eye is not, so let's say they're 20/40 in both eyes. Now they may be 20/40 in both eyes because of a cataract, but they also may be 20/40 because of amblyopia. So, you always have to make sure, is the cataract or is the vision that you're expecting, from your clinical exam meeting with what the patient's reporting. So if you feel like they're, 20/40, but they don't have much nuclear sclerotic, or, they don't have much, signs of change, look, is there a refractive difference? Is one eye really hyperopic and one eye, not so hyperopic, or is there any anisometropia? So these are, have they ever patched in the past? Had they ever had any strabismus surgery? These are history-taking questions that'll let you think that this 60-year-old actually has amblyopia in that eye, and therefore they're more at risk for diplopia postoperatively.
Okay. How about a patient who has, long-standing, let's say, cataract in one eye, and they have an exotropia, and now they want to have surgery done, and they don't remember, what their vision was, but it was never really great, but it's gotten worse now, and they want to have cataract surgery. They have a clear, let's say, 15 prism diopter exo or greater, let's say. Is there anything particular that the surgeon should do beforehand in terms of preparing or to assess for the risk of diplopia post-op? I know I'm throwing out these general questions, but these are kind of everyday things that you kind of see sometimes that come through.
I think in those cases, one nice thing to do is ask them for a picture when they were younger and see if that eye was out that 15 or 20 prism diopters when they were younger, or has it started to drift since they've gotten the cataract. That also can be kind of helpful. If they've started to drift off and their angle has changed significantly, then as Ryan was saying, if they had a suppression scotoma, they can be out of it, and they may get some diplopia, especially if it's the non-dominant eye, exactly as he was describing. So another question would be, has it gotten worse? If the answer is, yeah, doc, my eye has gone way out and it's much worse than it was before, and I'm not seeing as well, then it's probably worth a referral, because the question then becomes, if the eye was a lot straighter, do you want to straighten it first and then do the cataract, or what order? Or what do you want to tell them so that, again, their expectations can be managed appropriately? If you were to do the cataract first, which would be fine, they need to be warned, you may very well have diplopia. You've seen my buddy. If need be, you can be helped with that, but this is the situation. So you can explain to them exactly what may happen, what might occur after the surgery, and the potential resolution for that, so that they're more comfortable with it, and they're part of the team.
And to add to that, one of the questions that I'll get from adult patients a lot who are dealing with both a strabismus and a cataract is they'll ask me, which surgery should they have done first? I guess there are exceptions. We're kind of talking about some specific scenarios here, but in general, I would say to the patient to have their cataract surgery done first. Yes, they need to understand there may be some diplopia afterwards, but we strabismus guys can treat the diplopia. I like, before I do strabismus surgery, whether it's a youngster or an adult, to maximize the visual acuity in both eyes, because I think my post-operative alignment, hopefully orthophoric or close, is going to be more stable the better the vision is in both eyes. So in general, I would ask the cataract doc to take first dibs on their surgery, and then have the patient come back, and I'll deal with the strabismus that is there after the surgery.
Okay, I'll throw one more, because I see a referral for this one. This patient is as a youngest 35-year-old patient with who's basically a moderate myope, who wears glasses and wants refractive surgery and has an intermittent exotropia. And the question is, should this patient have LASIK done? Any thoughts on any cautions on these patients?
Do they have any control at all? Because if they're youngish, is it like a constant exotropia, or is it something that is
intermittent? It's intermittent. It's tired. It's there. You can bring it out sometimes.
So the LASIK surgery and correcting the refractive error, they actually, maybe the patient is using their myopic refractive error to help them control the intermittent exotropia. So it would be a very prudent conversation to have before the LASIKs to say that we may be improving your vision here. You may not be as dependent on glasses for blurred vision correction, but they actually may be using those glasses to help control their intermittent exotropia, and they may have to address worsening exotropia after their LASIK surgery, and they may have to come and see us. So it's a possibility that is best discussed before the LASIKs rather than after the LASIKs.
It's also a fairly common practice with these people with intermittent exotropia to over-minus them. So this is really important to make sure you like if you're seeing that they're an intermittent exotrope and you're doing your cycloplegic refraction, comparing it to your manifest, and you're finding it's like a diopter and a half less myopic than what they're currently wearing, that would make me highly suspicious for kind of decompensation if you go and you treat them for the cycloplegic, or if you do treat them. because they're not going to get that extra minus that they're used to control, because they're going to be perfect. So it could decompensate in those situations.
I think one of the things that you're sort of saying as well is that you should measure for the even it takes about 2 seconds, but measure if there is an ESO or EXO before you do your LASIK. I see many patients that have not been checked at all, and they're either ESO or EXO, or they're off and they're not happy. So it's important to have that measurement so you can do the discussion and then proceed with the right expectations.
Yeah, I mean, I think that you guys hit the nail on the head. I think that we need to be looking at those things. And certainly, I think, yeah, I mean, prior to refractive surgery, some of these patients have some pretty, far out scripts. And I think assessing for any kind of deviation, intermittent or otherwise, I think is prudent, and documenting it. And that's exactly right, as you've all said. I mean, this particular patient actually had turned out was over minus, and that provided some assistance in overcoming the intermittent exotropia. So I think that's a great point. Also, in the cataract world, we can also sometimes induce post-op diplopia for the same reasons, depending on what our refractive targeting is. So yeah, I mean, although many of us don't get into actually treating diplopia, I think having an understanding of what things we can do that sometimes causes diplopia post-operatively. And again, cataract is such a common procedure, LASIK being a common procedure. Every year I seem to find patients that get referred to me that have had surgery and they have, these post-operative issues. Luckily, we have great people like Andy Budning here to try to sort them out, but it's always better to know this ahead of time to warn patients at least, and maybe even to potentially alter your refractive target in some cases, depending on what the situation is. So thanks for that feedback for the group here.
Here's another tidbit for you. For people in comprehensive practice or in cataract practice, glaucoma practice, if you've done a surgery on the patient and they come back for their post-op visits and they're complaining that they have diplopia, keep in mind that as much as I hope it doesn't happen, something about the surgery may have induced some monocular diplopia. Mm-hmm. And so before referring the patient to a strabismus doc, where we might be able to help the patient for some binocular diplopia, we're not going to be very helpful for the patient who has monocular diplopia. So asking the patient if the diplopia goes away with either eye covered, or if it persists when one eye is covered, goes a long way to avoiding an awkward situation where we're in the strabismus world telling the patient that they have a monocular problem.
So true. So true. My fellows know that because it's something that we always insist on. It's so true on that one. And I'll also add, sometimes you get a patient who does describe, but the patient's describing sort of diplopia or double vision, as they may call it, monocular, but in fact, it may be some ghosting from refractive error or from some corneal issue. And so really you need to kind of hammer that home. But of course, first of all, differentiate monocular from binocular. Monocular diplopia is a fascinating, symptomatology that, has a whole bunch of things to think about, whether it's real or not, and then doing the differential for that. So certainly, yeah, well reinforced to make sure we look at that. It is something that I'm glad that we're talking about because, some of the most unhappy patients I have seen have been patients who have had IOL surgery, refractive surgery, and have post-op diplopia, binocular diplopia. They are very upset. And I think, as we heard here, it's prudent on us to basically assess. I think every patient should be assessed for deviation, and alignment pre-surgery. I mean, and that includes glaucoma surgery as well, by the way, because it's important to document it, and also important to perhaps counsel the patient, or maybe get a consultation from our strabismus specialist to prepare or plan ahead of time. So I know I bug Andy a lot. I appreciate it, Andy. And we ought to combine cases together, which is helpful. So great pearls. Really enjoyed this discussion. And Ryan, these are some tough cases, man. Thanks for starting off a bit lighter, but you got into some pretty heavy stuff, and it's incredible what you do. And I always love this because there's the science behind the surgery that we do, but clearly, as you've seen here, there's an art, and that art is the beauty of medicine that can't be taught by just reading a textbook or doing measurements. And I think you've described this quite nicely with the options that you have here. So greatly appreciate it. Appreciate Ryan, you presenting these cases, Jeffrey for your expert commentary, Andy as well for your expert commentary. It's kind of nice to see the camaraderie as well. And this wasn't really rehearsed. I don't think it's rehearsed. I know that. So it's nice to see the alignment, truly, literally, and figuratively as well. Matthew, I don't know if you want to add any last comments before we say goodbye, and really appreciated the discussion we had from the panelists and from the participants as well. It's great. It's nice to be able to cover a topic we haven't covered before, which was strabismus and surgical correction and diplopia, which is great. So Matthew, any comments before we finish off?
Thanks, guys. Yeah, no, I really appreciate you guys. And yeah, we do try and, encourage this natural organic chat, and so much interesting stuff comes out of it when we do it that way. So I like it. Can I throw in one more quick question, because it's a buddy of mine, Brian Schaefer, who'd presented before in Prism Rounds. He was asking about, is it reasonable to consider premium IOLs in patients who understand that they will need strab surgery afterward if they have, prior strabismus? Like, is that ruling them out for a multifocal or a premium IOL?
I mean, premium IOL, presumably talking about presbyopic lenses. So basically trifocal lenses or multifocal, right?
Mm-hmm.
You're talking about. Yeah. I mean, a toric lens, I think, you're correcting refractive error. I think that seems to be reasonable. Just like you correct the spherical error, you correct the cylinder error and reduce perhaps the burden of their spectacles if they're wearing prisms, for example, or whatever. But I think a presbyopic lens, I don't know what the group thinks here. I definitely would be very hesitant in doing that. I think that we're potentially creating issues, and already multifocal lenses are very finicky, and even in the best of eyes they can create issues, whether it's dysphotopsia, quality of vision issues due to some decentration or even just the optical system or aberration. So I don't know what the panelists think. I don't know, man. I would stay away from these patients. And just to add in there, I would also, I don't know what you guys think, I would avoid monovision in these patients too. I think that balance is important, and although it's tempting to try to give them some patients, I don't know what you call it, it's not really spectacle freedom. They still got to wear something if they're not clear, if they're not aligned. But I just wouldn't mess around with the system, man. Keep things consistent. What do you guys think about that?
I would agree with the monovision for sure. That's an absolute no-no in a patient who has any misalignment at all. It leads to major issues, and possibly if you're doing a lens exchange, if it's bad enough, or a laser to correct that. But as far as the multifocals, I think they need to be checked. There's some rare instances where I think they can be of a benefit, but in most cases, I agree 100% not. But if there's a question, I'd get them to see a strabismus person and just ask them if they have, depending what type of strabismus they have and what they're doing. But in general, I agree, Ike, you're right on. Stay away, but especially that monovision it's a big issue in patients who have strabismus.
I mean, the patient who's got some mild amblyopia in one eye, maybe 20/25, 20/30 in one eye, and the other eye is perfect, and they have more of an anisometropic amblyopia, and they have no deviation, they've been aligned well. I think you could push it a little bit and think about a multifocal, or maybe go for an EDOF lens, perhaps a little more forgiving. I would still counsel the patient, because expectations are going to be pretty high, right? Patients paying a lot of money, I want spectacle freedom, and they're not going to have that full perfect binocular fusion, perhaps, So I would, again, that may be the one where maybe you could think about getting away with it, perhaps, but still potentially at risk. But I'm assuming the patient, though, again, has good alignment. They've not had previous surgery, and they have just mild degree of amblyopia. That I think patient could be okay.
Do you ever play around with contacts in those patients?
Yeah, I love contact lens trials. I think that's really great point. We don't use it enough. Even a multifocal contact lens trial, right? Distance or a near.
That's what I was thinking.
Yeah, I mean that would be reasonable. I think completely reasonable, assuming, of course, their cataract is not overly dense. in this day and age, we get patients who want to have surgery right away and they want to get the, result right away. I really caution against that. I mean, do a continence trial, see what they like. Treat the ocular surface, for example, if they have it. I mean, I have patients who have bad epithelial basal membrane dystrophy. I'll do a PTK SK before doing any treatment, as an example. Same thing with regards to patients who have these issues that may require a bit more consideration. So I love that. I love that point. That's great. We got some greetings from Indonesia. Nice to see that. Really international crew here. Any more questions, Matthew?
We got to most of them. I don't know how much more time we have, but there were a couple of questions about lessons for us in glaucoma in general. I think we addressed most of those, but
the only thing I'll add about diplopia and glaucoma, I don't know what Ryan, Jeffrey, and Andy think. Those are tough. I mean, they can be restrictive, or they can be, mass related. They can be, neuro related. And I think, as Jeffrey said at the very beginning, I think it was before we went on. I mean, usually the IOP is the key here, right, for these patients, and keeping that nerve healthy. So, have any of you had experiences operating on patients with diplopia after glaucoma surgery, and your approach? I don't want to open a can of worms here, but just some general thoughts.
Well, I haven't done much, but I certainly would try to avoid doing strabismus surgery in the area of the glaucoma device. So your devices are usually superotemporal, supranasal. I would stay away from that muscle and try and plan the surgery without operating on that muscle. If I operate on a muscle that's remote from the device, I don't really think I'm putting that device in danger if I'm doing careful surgery. So that's my caveat if I'm doing surgery. I guess my hope would be to try and emphasize using non-surgical treatment rather than risking even doing strabismus surgery away from the device. I would be counseling to try Prism. And usually the patient is motivated not to lose control of their pressure and try Prism. And so I would try to treat medically. And if I do need to treat surgically, then I would try and stay away from the muscle in the area of the device.
The problem is a lot of these are non-competent strabs, right? And sometimes they're a mass effect, so we have to differentiate that, like an Ahmed valve with a big hyperencapsulated bleb. That's a mass effect. Sometimes it's restrictive at the muscle. Any success in thinking about Botox in these situations? Is there a role for that to kind of see what you get out of it, or you think that's not really useful in those cases?
Yeah, no, certainly done Botox in a number of those cases, and it can be pretty helpful. Occasionally, you can end up doing something if the other eye is pretty healthy, but you have to be really careful that it's not an eye that can run into needing glaucoma surgery. So you want to stay away from anywhere that might need surgery. But no, Botox can often be pretty helpful, but not for a superior. It's usually limitation in elevation. So you can hit the inferior with some Botox, and that'll help the eye to elevate better, and that can make a difference. So the big thing, of course, though, is you have to repeat it usually every 7 to 10 months, that sort of thing. So it can be a longer term treatment if it's working well, but they still end up with some diplopia because of the restricted nature of it.
Yeah, these can be nasty. I mean, even after, not just even after the glaucoma devices, a trabeculectomy or some of the newer microshunts. Matthew, you've probably seen some revisions we have. Some of these scars are like they are just encasing that muscle. And I tell you, Ryan, Jeffrey, Andrew, you'll be really proud of me dissecting around that muscle and taking that scar off and actually resolving the diplopia. But that's rare. And those are in patients who actually have blood failure. So I don't have a lot to lose. I'm going to go in there and I'm going to, remove that scar. And
I found like amniotic membrane works really well to prevent a lot of that scarring. So when we're removing scarring for a lot of different reasons, amniotic membrane is really great to prevent rescarring of the area. So that's what I've used a lot in terms of a lot of my restrictive strabismus cases. If I find that I'm removing a lot, I can, put some amniotic membrane in the area to try and help prevent the scarring from recurring.
Interesting. Okay, that's great, Pearl. Well, listen, I don't want to keep you guys much longer. Really great discussion. I mean, this is some of the best part about these rounds is just having a back and forth here and throwing out some great pearls. It was fantastic. I should let my American friends go back and check out the election. I wonder if there's a state that got declared. Maybe, I don't know. We'll see. Or maybe another lawsuit came down or something else from the Supreme Court. But we wish you the best. Thank you so much again, Ryan, for taking the time and presenting here. Jeffrey, thank you for your expertise and your wisdom. And Andy, I mean, thank you for just being such a force in strabismus and all these tough and complicated cases. Really great. I know the group really enjoyed it. I really enjoyed hearing from you and your pros as well. Matthew, thanks so much for organizing this. We'll be doing this again in a couple of weeks. So hang in there and stay tuned. A lot of different topics coming through, and this is a great hearty group. So we appreciate that. Wishing everyone a great night, everybody. Peace.
Alrighty. Thank you.
Hey, should we get a screenshot? How about a screenshot?
For a screenshot.
Oh, okay.
See.
Wait, first of all, we got to stop sharing here. Hold on. There we go.
And then gallery view, huh?
Yeah, I got it for you. Here we go. All right. Ready? 1, 2, 3. Fantastic. Great.
All right.
Alrighty.
Have a good night.
Thanks, guys. This was fun.
Thanks.
Guys,
so
take
much.
it easy.
A lot of fun.
Peace.
Cheers.
All the best.
Sure.
Bye.
Great.